Yeah, okay. So I thought we have some more time there. So I thought we'll have one video and then we can keep it for discussion, okay? Look at this particular patient. This patient was operated in Iran. It's an Iraq patient in which they had put an ACIOL, phakic IOL. Now, from there, the patient obviously is from Iraq, so came back to Iraq. Some years later, developed endothelial decompensation, cataract, peripheral anterior synechiae, and a closed angle glaucoma. So now, the doctor from Iraq, who's a leading ophthalmologist there, referred this case to me. You can see now, I'm taking off the epithelium to see better. Look at the peripheral anterior synechiae on the anterior segment OCT. And you can see this is the anterior chamber phakic IOL. Look how mobile it is. That's why this patient will develop this problem. So the first thing I thought was, let me bisect that phakic IOL and explant it. So far so good. I took out one half. Now I've taken out the second half. Now you can see there's a membrane present in the lens. The mistake I did was, I thought let me take off that membrane. And here the problem started, because when I pulled out the membrane, I didn't realize at that time, somewhere I've ripped open the capsule. So now I can't find the capsule. The lens is subluxed now, and you can see I'm removing everything there, but obviously there's no capsule. Once you don't have that, I thought, okay, I'm stuck now. Let me see what I can do. I thought, let me implant the lens in the sulcus type, but I realized that lens is going down. You can see the IOL leading haptic in the vitreous. So I know now the only solution I have is to do a glued IOL. So you see I made my two scleral flaps. I'm now making my 22 gauge sclerotomy 1 millimeter behind the limbus. Now my next step is to do vitrectomy. I've got a trocar AC maintainer, and I advise everyone to move to a trocar AC maintainer. The same retinal trocar can go in the anterior chamber, 0.5 millimeter from the limbus, going through the sclera. But the advantage is you know where the cannula is, rather than when it's in the pars plana. Once I've done vitrectomy, I'm now going to catch the haptic, and I'm going to do the handshake technique again. So you see I'm transferring it from one haptic to the other, catching the tip of the haptic and externalizing. So far so good. Now I go in for my handshake technique. So you see now I'm transferring it again from one hand to the other. This is the no assistant technique also which we use, and both haptics are externalized. Once both haptics are externalized, I tuck the haptics into the pockets of Charier's 26 gauge needle creates that. Now I have to do the pupilloplasty. Those of you who haven't mastered this, please go back and start this. It's a very simple procedure, single pass, 4th row pupilloplasty. So here you can see I'm doing that, making the principle that my pupil has to become smaller. Now notice here, there are peripheral anterior synechiae. If you don't break those synechiae, when I'm putting my graft inside, that air will not fill in that particular area. So now my next step is to break those peripheral anterior synechiae, and in the bargain you notice I have created an iridodialysis. I don't mind this because in this case I know if I don't create and break that synechiae, this patient will never become all right. But now once you have that, I have to do a trocar assisted iridodialysis like how Rohit showed you. So where is the trocar fixed? Right opposite the area of the iridodialysis. Now you take a double armed proline suture that goes through the iris, comes out through the sclera. That's the one arm. Then the second arm goes through the iris again, comes out through the sclera. You can see there, and it's coming out under the flap area. Now all I need to do is pull on both ends. And when you pull on both ends, you'll notice, see how when I pull, the iridodialysis will get repaired. You can see that repair. But remember, one problem is there. When I pulled it on one side, my iris also has gone off to one side. So what you do now is combine it with a 4th row pupilloplasty. This is the twofold technique. I'm combining the trocar assisted iridodialysis with the 4th row pupilloplasty. Now watch my Perkins image, bang centered. So far so good. now I'm extremely happy. All I need to do is shift to air. Once I've done air inside, now I remove the endothelium, desmoid complex, take my PDEC graft, pre-desmoid endothelial graft, inject it inside, and I think I should be quite happy about it. So you see now the graft injected inside. Now the problem in such cases is, look at the patient post-operative day 1, and I'm extremely happy about it. When I saw the patient later, because that air was in the eye, I got a heart attack, because pre-operatively was PL, post-operatively was still counting figure 4 meter, though the graft was clear. Now I was scratching my brain and saying, why is this patient not seeing? Remember, this patient is an Iraqi patient, gone all the way to Iran for phakic IOL, come back to Iraq, and now come to me. So there is no way this patient can go back to Iraq and come back. Now I realize my biggest mistake was I had messed up in the IOL power calculation. Now I don't know what to do. So please remember, this is just 1 week after the glued IOL, after pinhole pupillasty, and after PDEC. But I had no choice. I had to take the patient back to the operation theater. He's -10 now. Now my problem is, I've got a pinhole pupillasty. I have to first of all break the pinhole pupillasty. So I'm breaking it with iris hooks. Now I have to dislodge the glued IOL. And remember, all of you ladies and gentlemen, there's a PDEC graft inside the eye. Okay? So there's an endothelial graft inside the eye, and my heart is really scared right now. So now I see I'm carefully explanting this IOL. I'm making a scleral incision there, tunnel incision, and I've explanted it. Now I'm going to re-implant a fresh new IOL of the correct power and gluing it inside. Once I have done that, I again have to do a pupilloplasty. Remember that we did a pupilloplasty, I had to break it. So after vitrectomy, I'm now going to do again a pupilloplasty. Now watch carefully, I'm doing it on one side. Now I'm doing it on the other side. Remember, that's just 1 week back, we had done a PDEC graft. Now look carefully. There, I got a heart attack again. You can see that PDEC graft there. So I thought, let me not test my luck anymore. After this gets fixed, now I say enough is enough. I'm just clearing up this pupil area there, and you can see there the Purkinje image P1. Look at the inverted Purkinje image, that is P4. Don't worry about that. But touch wood, the advantage in this whole surgery, if you notice, is my PDEC graft has not dislodged, and that's a big advantage of PDEC. So now I fix my glue. Now the question is, post-operatively, patient improved to 612. So if you see pre-operatively, patient was PL. We did anterior chamber phakic IOL explantation. We did the glued IOL. We did the pinhole pupillasty. We did the PDEC, but made a mistake in the IOL power calculation. So we had to do a glued IOL exchange and again do a 4th row pupiloplasty. The patient vision improved to 612. Saying that, ladies and gentlemen, I'd like to thank Kumar Doctor and the rest of you all for coming for this final session of ours. Thank you very much.